You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. Today's episode focuses on the recent CMS price transparency rule. Host Senior Health Information Technology consultants Gary Austin, Ken Kleinberg, and Pooja Babbrah discuss the new rule, break down its components, and outline what it will mean for the industry across stakeholders. We hope you find today's episode helpful and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Good day, everybody, and welcome to the ongoing adventures of The Dish on Health IT. I'm your host, Gary Austin, affectionately known as Lumpy. We at Point of Care Partners are health IT consultants with 100-plus associates in over 35 states. We work across all stakeholder groups, payers, healthcare delivery entities, pharma, health IT vendors, HIEs, and government agencies. And we're viewed as an independent, trusted party, the Switzerland of consultancy, just with less chocolate lying around. Joining me for this episode of The Dish is our new technologies lead, Ken Kleinberg, and Pooja Babbrah, our PBM practice lead. Ken coming from upstate New York and Pooja from Phoenix, Arizona. This episode, we're going to focus on price transparency in healthcare. A lot of motion in the market the last few weeks around this. And we've done a couple earlier podcasts on the topic, but we wanted to update this with the new rules that have come out from CMS. Ken, how about you start with baselining us on the concept of price transparency? What's it mean? Where did it come from? Maybe a little bit of a historical context.
All right, thanks, Gary. When I grew up, doctors were revered, and it was a very lucrative profession. Consumers were not really concerned about the cost of their doctors because it was basically handled by their insurance companies. Now, this was a fee-for-service model. You had health insurance, in most cases from your employer. Employees had jobs for life. I mean, remember when we got 50-year watches? And the challenge was costs just kept going up. I remember reading about one of the big car manufacturers claiming that they spent more on healthcare for their employees than they spent on steel for their cars. More recent example, Starbucks claimed that they spent more for healthcare than they did on their coffee beans. In fact, our costs here in the U.S. are about double of any major country in the world. And it has been claimed for a long time to be unsustainable. And it makes it hard for us to compete on a world stage, in a world marketplace. So over the years, the government started to move towards more of a pay-for-performance model. Private insurance follows along. We've got bundled payments. We've got Medicare shared savings programs, value-based care, all the way up to the more advanced models now, accountable care. And as part of all this, patients with their copays and deductibles are starting to play a much greater role. The consumers are getting more engaged. And when they are looking at the health plans that they can afford, a lot of them, unfortunately, are moving to these high deductible health plans that really only cover them in a severe emergency. It's effectively self-pay for these patients for, let's say, up to $6,000. And it's hard for patients to afford. So they're starting to push back. And what we're also starting to see is as patients complain about costs and what seem to be inequities, there's a disclosure of just how complex pricing really is. So now we're looking at requiring providers to disclose how much they charge. We're looking at payers to disclose how much they pay. And consumers should get a better view of what they have to pay. So in theory, this should increase competition, give us more of a market, and reduce costs. Or will it? Back to you.
Got it. Wow, that's a good overview. Quite the mouthful there, but yeah, there's a lot going on in this space. So Pooja, being our Queen Maeve of rules, as I understand it, there are some CMS pending rules around price transparency directed at providers, right? So how about we start with those first to baseline our audience?
Sure, yeah, and I agree. There's a lot to unpack here. So if you count everything, actually, over the past few years, I think we actually have 5 rules around price transparency. And we've seen a couple of those get finalized in the last few weeks. And that the one around the provider rule, it's actually a final rule that came out. So as Ken mentioned, part of it, the goal around all this is to make sure that providers and payers are essentially letting consumers know how much things are going to cost them, right? So the provider rule was actually finalized almost a year ago, I think last November. And it immediately, the association, hospital association and others, put in a lawsuit to try to stop it. The judge ruled against the associations, and so it did become a final rule. But essentially what it requires as of 1/1/21 is they have to, providers have to give a machine readable file essentially of standard charges. So that can include gross charges. It can include payer specific negotiated charges. So we know, something that I go into a hospital for under my insurance plan may cost me something different than the one you're on. And so hospitals and providers actually have to make available what their payer-specific negotiated charges are. The third piece of it is they also have to let patients know if they're coming in and paying cash, how much it's actually going to cost them. So it really just allows a consumer to better understand what their charges are going to be if they're going in for some kind of service or procedure. So it's really, I guess they're requiring providers to really open up their kimono, right? So the other piece of it, so that's the 1/1/21. And the other piece of it is the providers actually have to provide in a consumer-friendly format to consumers the price of 300 shoppable services. So this could be x-rays, it could be lab draws, and it can even be bundled services like, someone going in for a C-section. And so you have to be able to provide that somewhere on your website or make it available to patients so it's easy for them to understand what it's going to cost them if they go to that provider.
Got it. So if I'm in the provider world there, just to play on that a bit, it seems to me like, I've got a huge infrastructure built up around this sort of piece rate capture and piece rate billing, right? That's the whole charge master problem in the industry, which is the root of a lot of our issues here, right? And things like that. It feels to me like it would be a whole lot easier to do things in this sort of model with, predetermined service costs and bundled packages and things. It probably lowers my accounts receivable. Patients know what they expect. They can actually pay the stuff. I don't have to be screwing around with negotiating all the time with folks, right? Is that the way most providers you think are looking at it? Are they looking at it at, oh God, hair on fire, this is going to be the end of the world. We're going to tell people what we actually charge for things?
Well, I think, we could see from the lawsuit, right? I think initially it was the hair on fire. How are we going to do this? You guys are forcing us to do this. But I think those providers that are actually thinking about it in a way, it actually could be a huge advantage for them. We're trying to push for this value-based care, for capitation, those kinds of things. And this could actually accelerate that, right? And I think the forward-thinking provider groups and hospitals should be thinking of it in that way, as opposed to, oh gosh, I'm being forced to do this and it's gonna cause all these issues.
Got it. And then last week, CMS or HHS announced some new price transparency rules for payers, right?
Yep.
So tell us about those and how do they sort of offset the provider ones?
Yeah, so from a payer perspective, it's a lot of it's the same thing, right? But as a payer, you also have to provide to the patient what it's going to cost for a cost sharing portion, right? So I'm going in for surgery. I need to know how much I'm going to pay out of pocket, whether I have, a deductible, whether I'm whatever plan I'm covered under. So it's, again, really pushing to allow the consumer to understand and, how much it's actually going to cost them for a procedure. But the other thing it's doing is allowing patients to actually kind of price shop for coverage, and understand a little bit better what are they really getting for their coverage, right? I mean, today, if you're covered under your employer, you're basically given just a couple options, right? And you usually see what the deductible is or what my copays are going to be, but you can't really shop around to understand, okay, if I want this procedure, how much is it really going to cost me? So that's really another kind of aspect of the payer rule that CMS wanted to push forward. And what's interesting is, usually when we see rules from CMS, they only apply to the Medicare and Medicare Advantage plans. The payer rule actually applies to commercial plans as well. So that's a change that we haven't seen in the past.
Wow.
Sorry.
Yeah, that's a big deal. I didn't realize that. So yeah. Payers and providers then, not just governmental payers, Medicaid and Medicare.
Right, it's commercial payers as well.
Right, it's commercial also. So payers, providers, anyone else come into play here with price transparency rules?
Well, not with these specific ones, but as I mentioned, we've seen, I think, 4 rules drop and 1 pending. So in the past, we had 2 rules around real-time benefit check, which is essentially requiring payers to provide to providers or to consumers the ability to understand the price around a medication. And so, from a PBM standpoint and a pharma manufacturer standpoint, I guess you could say, there's information that's being required to be shown to the provider when they're going to prescribe a medication. So that's another kind of rule that's out there, not specific to these 2 rules that just dropped recently, but ones that are in play, final rules that are out there as well.
Got it. So pharma's using this, what is it, RTPBC, right? That's the acronym sandwich, Real-Time Pharmacy Benefit Check, right?
Yes.
After what, 3 years, I finally got that acronym straight in my head. That you and the folks at NCPDP worked on so hard in the past few years to get that through and whatnot. Is that same transaction going to be used for medical billing or something analogous to it? Or how is this going to be operationalized? Or is it just going to be, hey, here's a CSV file or an Excel file or something sitting out on a hospital website and it's your problem? Go figure it out.
Yeah, so part of the payer rule actually includes medications. And so we're actually, so on the NCPDP side, I know they're kind of looking to see how the rule unpacks. We've been working, and I think we mentioned this on a couple podcasts, that, the Karen Alliance is working on the patient-facing real-time benefit check. And we actually are going to be unpacking the rule as well to understand the transaction that we've created. Would it work for that or not? I think the difference is the negotiated rate. So today with the real-time benefit check, you're actually just showing the patient pay portion. You don't have to show the negotiated rate. But that's a piece. If you added that, I think the existing transaction could work. So some work that needs to be done, but I think that transaction could meet that mandate.
Got it. Good. Okay, good. Excellent. Okay, so this is a great job about the rules. Thank you. So, I mean, I'm in the field here and I don't understand half of them. You just can't keep up with them. They're sort of moving so quick right now. Yeah, right. Yeah, and my attention span is 6 paragraphs on a really good day. So, that's a heck of a lot of new rules applied across a wide swatch of the market here, right? Payers, providers, and pharma. So Ken, in most other industries, they haven't required government intervention to drive price transparency. I'm thinking like Amazon and retail and Kayak for travel and, Auto Trader, let's say, in automotive and things like that. Ken, why do we need governmental intervention here? What's different about healthcare?
Yeah, well, I think healthcare is a lot more complex than when you're purchasing an individual item or a very well-defined service. You're taking an airline flight, for example, they're going to carry you from here to there and you've got some bags. Maybe you'll get a meal. With healthcare, what they may do for you when you're at the emergency department, for example, you come in with a concussion, Now, are they going to just run a few tests? Are they going to run a lot of tests? Are they going to discuss the price with you about every part of that? Think about a car. Over the years, it's gotten easier to buy a car with the sticker, and you have a lot more information that you can get on consumer sites about the price, about the reliability, and so forth. So you got that in your pocket. And I remember when this was first becoming more common, you could go into the dealer and you had a little bit of information, but there was always one more thing they could find to get you, if you will. But eventually we've worked a lot of that out. In healthcare, we're just at the very early stages now of how we're going to deal with price transparency. And you think about all the complications when a surgery is taking place, for example. As someone once stated, I would take the consumer's view of how something should cost with a lot more credibility if the patient had gone to medical school. But they hadn't, right? So you got to trust me as the doctor to know what had to be done here. So there have certainly been some limits on some other industries, and we've had some crackdown when necessary. But healthcare, I think, just due to the complexity, has been the hardest to go after, and I think that's really the biggest issue.
I'm thinking about you mentioned the car space there, and so I have a cute little Mini Cooper, right? And when I bought that thing, it was sort of no bundled packages. You decided what color you wanted on the mirrors, whether you wanted chrome or the color of your car or little British flags or whatnot. You decided if you wanted, neon headlights or halogen headlights or whatever the options were. A friend of mine just bought I think it was a Toyota, but some SUV, and she only had like bundled options for the most part. So, we live up north here. She wanted a winter package, and the winter package only came with a moonroof. She's a kayaker, can't put the kayak on top of a moonroof very well. Not a great plan. And so she's like, well, all I want is like heated seats and maybe some heated mirrors or something. I don't want a moonroof, and they wouldn't sell it to her. Do you think we're going to run into that sort of problem with healthcare here, where they'll bundle stuff up so grandiose, and even if you don't sort of need some of the services, you're still going to have to take them?
That's interesting. It's like getting married, right? With the wedding package, you may have all these ideas of how you want to have this custom wedding, but what the wedding planner is really trying to do is to give you the cookie cutter wedding that they're the most familiar with, that they can control the cost most carefully. But as we say, in healthcare, there are a lot of variables here. We have seen, for example, certain prices set for joint replacements, and the payers are on top of this, the bundle payments, and this concept that a group of providers are going to work together so that they have a better handle on what it's going to cost them, and they do a lot of them. So in anything that's very repeatable, it should be possible to get to a very clear price. And then it comes down to, can you deliver at that price with greater and greater efficiency? And that is a direction we want this to go.
Got it. So to me, this sort of gets to the heart of this whole surprise billing thing, right? Which is just a real thorn in my side. So as you guys know, I had some eye surgery done last month, and my eye clinic told me up front it would be roughly $6,000 for the surgery. Okay, so I set that aside, and I was fortunate enough to have that much cash available. Not mentioned was that the surgical center had its own billing over and above that. Oh, and the surgeon had his own billing over and above that. And the specialty eye drops that I needed to take, which were not inexpensive. And then throw in the anesthesiologist. So I think I'm up to, and by the way, it was like 10 post-op appointments that weren't factored into that. So I think I'm something at like $9,000 now, so a 50% bump, and still clicking away at the cash register. I got 2 more bills yesterday, unexpected bills, surprise bills. So, good surgical outcome, but this left me really, really angry with the whole experience. Can we expect that these rules will obviate the surprise billing situation? So, Pooja, why don't you react first, and then Ken?
Yeah, so I think that's one of the downside of all these price transparency rules. I mean, you would think as a consumer, I mean, we can unpack it and understand it, but if I, heard about this and I'm thinking, great, now I know how much it's going to cost me, if you think about it, it actually doesn't because the providers are expected to do these prices on these 300 shoppable services. But to your point, that may not count the pre-op, right? It may not count the post-op. You're getting some kind of surgery done and you have to go for physical therapy afterwards. It may not count that cost in that. So I think that's part of the problem is we're saying yes, this is available, but it's not covering the actual event. It's just covering the individual kind of
Not
pieces
the
of
end to
it,
end.
right?
It's still
Not the end to
transactional,
end.
right? It's not
It's
the end
still
to end service.
transactional. So I know our goal is to eventually get there, but we're not there with these specific rules. But just around surprise billing, one thing I think that's gotten lost in all of this is there was an executive order that came out like literally right before the election. And that was supposed to, so the idea around that is to, kind of address this surprise billing, right? So patients can understand a little bit better the surprise billing piece, what hospitals are going to or providers will come after you for, what's going to be required out of all that. And it's not an actual rule yet. It was just an executive order. And so, kind of this trifecta, right, of you got the provider rule, you've got the payer rule. So the third was the surprise billing. But given the change of the administration, with the executive order, we may not actually see a rule come out from CMS for a while. I think the question then comes up, do you think this is going to go away? Personally, I think, all this price transparency has been bipartisan all along. And so I think we will actually see a rule come out of this surprise billing executive order, but I think it's going to be delayed, just with everything being shuffled around. So
Got it.
yeah, I think it's that's the ultimate goal is for you as a patient or for I as a patient to go in and understand truly what my cost is going to be, but we're just not there yet.
Got it. Ken, how about from your perspective around surprise billing?
Yeah, you go to a restaurant and literally the menu is posted out front right before you go in. I'm thinking of urgent care centers as being an alternative to the emergency department and being far less expensive. So what have some health systems done? They've created freestanding emergency departments that look like urgent care centers, and patients only find out once they're inside that it's costing them thousands as opposed to
Right.
the few $100s that they thought. So that's very concerning, and it's really a question of, consumers have to be more informed as they move into these healthcare settings. And the more information they have, the more reviews they can read, the better informed they're going to be.
Got it. Yeah, we had a big hoo-ha about that out in Las Vegas there. So just down the street from us, CVS or Walgreens or one of those folks, the big retailers, opened one of their clinics, right? One of their in-store clinics. And literally within 6 months, one of the, I think it was a faith-based hospital chain, opened a freestanding ED right next door. Much bigger signage, right? Come here first, don't go there. They're just a clinic type of thing. And, people started getting these bills that were in the thousands of dollars. And boy, it really got ugly from this was a front page of the Times sort of story and put a real hurt on them in terms of their PR and how their brand and things. So, let's talk a little bit about the consumer impact of this free flow of information. Pooja, any thoughts of what this is going to do to providers? Does this accelerate the move away from piecework and maybe towards capitation? Or is this just sort of it's one more mandate, I just got to throw some info out there, but nobody's going to probably read it anyways, and, everything stays status quo. Any thoughts?
Yeah, so it is interesting because as much as we all think that providers are looking for patients are looking for this information, there's some studies out there that say even if a patient's given all this information, they're not actually going to look at it. And I think, Ken had recently found some information on that. But I do believe that this is going to help us, at least from an industry, move away from this piecemealing to hopefully more capitation, right? I mean, so the idea behind capitation is, you're paid a specific amount. You're not having to negotiate all these different rates. And if you think about it from the actual rules standpoint, if you've got a capitated payment from a payer, that you're not disclosing that, right, in terms of your negotiated rates. But I think looking beyond that, providers need to be thinking of this as a positive thing, something they can turn into an advantage for them, right? Because, if you're actually able to get this information into a patient's hand, and then I think Ken alluded to it earlier, right, the quality information, there's no reason we as consumers cannot be shopping around to understand, I want to go here for this specific surgery, and look, their outcomes are really good. So I know if I'm going to go in, I'm going to come out better, right? And I think that's the way we actually need to be thinking about it, as opposed to, oh, this is a mandate that I'm having to do. But I don't think a lot of providers are there yet. Honestly, I don't know how to get them there. I mean, it's hard to when you've got these mandates, right? It's like, oh, the federal government's doing this again. But, if you take a step back, it's actually a good thing. And I hope people recognize that.
Feels like sort of lack of vision from their executives around what to do.
Yep.
This. Ken, does you brought up a good point there around quality. Ken, does quality now become an actual thing that consumers need info on versus this, ethereal concept that payers and providers just talk about, but never really gets in the hands of the consumers in an actionable way? I mean, I think about quality and performance data in other industries, right? So when I go to book a airline flight on Kayak, I look at things like, and I travel a lot, normal years, right? I look at things like on-time percentage. I look at how often that flight's canceled, that information's around, right? I look at my other options. So if something happens to my connecting flight, what other options do I have and things like that. And I assume I'd want to do that. I mean, does quality start now becoming something that you have to publish in order to compete?
Well, certainly quality has been measured in healthcare for a long time, and CMS, HHS, they've been dealing with quality measures in quite a bit of detail, actually. For example, you've got the Hospital Compare database, which not every consumer is familiar with. In fact, probably few consumers are familiar with it. I'm looking at data for the local community hospital where I am in upstate New York, and sadly, it's only got 1 star out of 5. Some of the measures here, mortality, safety of care, readmission, patient experience, effectiveness of care, timeliness of care, efficient use of medical imaging. My particular hospital here is below average on every one of those except one where it's, there are 2 of them where same as the national average, but not above it. So now what am I going to do? Am I going to not go to the community hospital that's near me and travel instead of 10 minutes or 15 minutes, I'm going to travel an hour? Maybe for something really serious and important, I would likely make that longer trip. And then you got to filter the cost information into this too. You've got the quality and the cost, and of course that adds up to value. So yes, combining information like this on quality with the cost information could be quite powerful. Got it.
Very, very good. Pooja, anything to add on to that?
No, I think that makes sense, right? And that's the whole key to the value-based care, right? That we're pushing for in the industry. So yeah, there is some information out there. I'm sure it needs to be improved. With the whole thing around FHIR and APIs and all of that, make it easy, right, for people to get that information, pull it into an app, right? I mean, yeah, this information's out there, it's kind of buried. I mean, I didn't even know about it until we decided to do this podcast and did some digging. So I think it's a matter also of just making it more accessible, easy. We all have our smartphones with us, make it available in a way that I can just pull up the cost and the quality all in one shot on an app. That to me is where we're trying to get to.
Got it. Very, very good. So yeah, it feels to me like when I look at Amazon or whatever, right? I look first sort of at price. And, if there's a whole pile of items that are relatively the same, if the knee replacements are relatively the same, right, plus or minus 5%, 10%, whatever that number is, Then the next thing I look at is quality ratings, basically consumer reviews, whatever else, exchange policy. Laugh at that, but I had a friend that actually had an exchange on his knee. He had his knee put in, thought it went through good. They messed it up. He had a recall on it a year later. He had to go back in and get another one done. That was not a good time. So, he's not going back to that hospital again. Could this lead us into, you got a lot of different constructs that come out of this, right? Could this lead us into something like, let's say, demand pricing for medical services? For example, as a patient, if I'm a late nighter, I'm not, I'm a morning person, but if I were a late nighter, if I could go get my MRI done on a really expensive machine at 11 p.m. instead of having to go at 10 in the morning, like they mandate me to go usually, and it would save me 25%, being a cheap guy, I'd probably do that. So, could it lead us down that front and allow us to get better utilization of big capital?
Absolutely. Yeah. I'm lived in New York City for a few decades, and, we're around the clock type of place. But you think about other parts of the country or more rural areas where, you're more just during the daylight hours. Why not have the facilities open at additional times of the day? I mean, there was a time, right? Remember when fast food was only for lunch and dinner, and now, of course, you can get breakfast. Why can't we extend healthcare into other parts of the clock and take advantage of less demand at those times and provide lower pricing at those times? Consumers should have that choice. And I think for many people, they would take advantage of demand pricing. The whole concept of cost in healthcare to begin with has always been one that, you weren't supposed to talk about making a profit if you were a hospital or a provider. Yet, I think we have to be more realistic about this as an industry as to what the consumer can afford and how we meet that need, and that will drive competition. So I'm in favor of this.
Got it. And my head immediately went to late night chalupas at Taco Bell. So. So let's wrap up with just a little. Let's pick one of the segments. We'll pick payers, okay? Because we could probably do a whole podcast on any one of these segments. But let's just talk payers for a sec. So, what's the opportunity for them there? How can they differentiate themselves in the marketplace? How can they use this for market advantage? How can they, increase stickiness with their members and things like that? Pooja, why don't you start, and then we'll go over to Ken.
Sure. So I'm actually going to zoom out a little bit and talk about the interoperability rules. So if you think about, from a payer perspective, you're now required to provide your members with all their data, right, that they have on you, clinical claims, all of that. So if you look at that and then add the fact that you're now also letting the patient know how much it's going to cost them for these services, this could be a huge advantage for you, right? I mean, make it easy for your members to understand everything about your plan and their coverage and how much it's going to cost them, and give them access to everything. So I think as a payer, you should really be looking at this as kind of that broader, engaging the member, engaging the patient, which is really what all of these rules are all about, right? We want patients, we want members to take greater control of their care. And as a payer, how are you going to do that? So I think this does provide a huge advantage. And if you wrap it into everything else that you're doing as a payer, I think you could go out to the market with a great advantage around this. It's just a matter of thinking of it a little bit differently.
This is sort of the extra-netting of your health data asset, right?
Absolutely.
It's making it available outside, and that's tough for payers, right? They live in a world of shrouded in secrecy, right?
Yeah.
They're the Vatican of financial institutions, sort of.
Yeah, but if you think about it, if you're a payer and you're ahead of everyone and actually providing this information, what a great way to kind of to distinguish yourself, right, in the marketplace. So
right, very good. Ken, you want to weigh in there on payer differentiation, and then we'll sort of wrap up after that.
Well, a payer potentially has more longitudinal information about you than any one provider that you may visit. So they are potentially in the best position to see that big picture and to help you. I'm thinking of an ad that ran in New York City for a long time about a clothing manufacturer that said, an educated consumer is our best customer. And if you're the organization that's educating your consumer, then you're effectively making them a better customer, and they're going to want to stay with you. So sure, I think there are actually a lot of advantages to providers in price transparency, in how they can go beyond just satisfaction to loyalty. And I think there's a real distinction there. You may not like the way you're being treated somewhere, but if they still offer the best capability, you're going to stick with them. And how you walk that line between telling people what they really need to know versus what they want to hear in healthcare, that sure seems to be a more important factor than it might be in some other industries.
Got it. Very good. Pooja, I'll give you final closing comments for the day. Why don't you take us out here?
Yeah, so I think, I know we have a lot of, clients, a lot of payer clients, a lot of provider clients. And I think the biggest thing is, don't look at this as a mandate, right? Like really kind of shift your thinking around this to better understand how you can actually use this to an advantage. Because I do think that if you are one of those groups that do that, I think, you're going to have a greater advantage in the marketplace until people kind of catch up with you, right? And I think everything we're seeing, getting this information to the members' hands, helping them understand a little bit. Yes, there may be members who don't care. They're just going to keep following the same thing. But I think there are a lot of people that are starting to pay attention. And I think this is an opportunity for payers and providers to actually, do the right thing, right? And kind of put their members first in some of this stuff. So,
Gary, I know you said you were giving Pooja the last word, but I also want to mention, we're talking about the payers and providers here. We've got these converged entities, right, that, pay Vita, if you will. And I think of an organization like Geisinger, which offers a price guarantee to patients, where if you're unhappy, there's an app and you just hit the button that says, I want a refund. They're going to ask you, of course, why you're unhappy. And those kind of messages go right to the top so someone can act on them. And that's very, very powerful. And there haven't been a lot of organizations that have followed suit with that. But the early success from Geisinger and just a couple of others, I think, is showing us a path forward.
Got it. I'm hearing three kind of major topics there. Extranetting your data assets. I was making some notes as we were talking. Get moving. Don't wait around. There's some serious marketplace advantage here if you get rolling on this. And really look at the end-to-end cost model. And that's, in the end, that's what the patient cares about. So, all right, guys, great session. Really good. I appreciate you both sort of hopping on this quickly after the new rules were announced here. For our listeners, we'll probably do another one of these, I would say maybe mid-quarter or end of next quarter, as we get a little more clarification on the rules and as we get a little better read on sort of what the new administration will be doing around this. I suspect they'll keep some of this. They'll probably change some of this. I doubt they're going to get rid of sort of the concept here. So, okay, well, that's our time for this edition of the Dish on Health IT. Many thanks to my co-hosts, Ken Kleinberg and Pooja Babbrah. Great, timely content here today. So please subscribe to us at whatever podcast carrier you use, Apple or Google or another one. If you have any speaker thoughts or if you have any comments or suggestions on this podcast, please email us at podcasts@pocp.com. Goodbye for now. And remember, Health IT is a dish best served hot. Good day, everyone.
Does your organization need help making sense of how to respond to the latest price transparency rule? Point of Care Partners can help. Reach out to us to set up an appointment to talk through your unique challenges by emailing us at info@pocp.com.